Um, Welcome, everyone. Thanks for joining us for our first meeting of the year of the Informed Prostate Cancer Support Group. I hope that you're all dealing well with the coronavirus. This resurgence with Omicron has certainly delayed our ability to return to meeting in person, but hopefully it will be happening soon. We know how important the in-person meetings are for people to be able to ask a lot more questions than they get the chance to here of even just fellow members. But until then, we will continue the live streams every month on the third Saturday of the month. So I apologize that my slides are a little bit unformatted. I'm not sure the cause of this today, but anyways, please bear with me. Your hosts of the IPCSG principles are Lyle LaRoche, who, as most of you know, passed away a few months ago. Again, I apologize. I thought that these slides were, this is a very old set of slides. Please give me a moment. I'm going to try to see if I have a different set here.
It was kind of nice having Lyle live on.
I know. I
sort of like that.
We really
nice tribute to him.
No, I do not think that is going to work. I'm going to walk through the slides this way. Apologize for that. I had pulled up the slides from last year instead of this year. So let's try this again. So yes, our principals are Bill Lewis, our president, who also does our newsletter summary, Jean Van Vliet, our director and treasurer, Steve Pendergast, our secretary, who does the wonderful job with the newsletters, Bill Manning, our director and videographer, myself, Aaron Lamb, director and facilitator of the meetings, and John Tassi, our webmaster. And then, of course, there's you, the 900 members going strong. Everyone is a volunteer, and you can be too.
Just seeing your face right now.
Oh, nuts. Okay, hang on. Sorry about that. I forgot to reshare my screen. Oh, boy. All right. So our support to you is in a number of ways, especially through our website, ipcsg.org. There you can find all of the past newsletters that contain a huge wealth of information. Many of you will likely also receive that in your email box every month. There's also the link there to the monthly video streaming that we do on the third Saturday of each month. We have a hotline number that's especially important to new members just joining us for the first time. Please go ahead and give Gene a call on that number that you see. It's also available on the website, and he can put you in touch with somebody that can, another member who can answer any question that you might have if he himself can't answer. I know that has been a very useful thing that we service that we provide, and unfortunately, again with my mistake on the slides, we've recently added Sharon Duffy to help out specifically running a helpline for the women, family, and caregivers of our members. Her phone number is available on the website, but it is also 619-982-3984. And of course, you could also get that number if you call the hotline number there that you see on the screen. So we do need volunteers to help out, to help recruit and schedule speakers. I believe that we are scheduled through at least through April. Bill Lewis has done a wonderful job finding new speakers for us throughout California. They certainly but the nice thing of the Zoom meetings is that we can have people call in remotely that we would have more trouble getting to agree to come in person. And all of you volunteers there share your experience. In fact, we have now scheduled a member roundtable for March. I can personally say that that was an incredibly useful meeting for me in particular. The one that we had 4 years ago was the first meeting that I attended, and it definitely put my nerves at ease in terms of trying to figure out what my next steps were in my treatment. We do need volunteers to help with those hotline calls, so go ahead and contact us if you would like to volunteer. So the main purpose of our group is that we share patient-focused experience on becoming your own case manager through informing, networking, and caring. We are a group of experienced participants, but we are not medical professionals, and any sharing by any one of our group may not be a substitute for your own medical counsel. And we do need your support. We are a 501c3 organization. Therefore, donations are all tax deductible. We have no medical or religious affiliations. And during the coronavirus pandemic, where we're video streaming our meetings, our costs still remain very much the same. We have the license to actually do the Zoom meetings. We still have the website. We still do advertise. So please do make a donation if you can. We've had quite a bit of support this past year. Everybody has been so very generous. Thank you for all of your donations. You can either donate online at PayPal or by sending a check in the mail at the address that you see. And again, that address is available on the website as well. In terms of upcoming meetings, we have our annual visit from Dr. Lamb next month on the 19th. He's with prostate oncology specialists. And as I mentioned, in March, we'll be having our member roundtable. However, for today's meeting, we again have our annual meeting with Dr. Mundt and all of his colleagues, Dr. Einck, Dr. Rossi, and Dr. Rose. All professors of UCSD's Department of Radiation, Medicine, and Applied Sciences, where Dr. Mundt is professor and chair, Dr. Einck, a professor as well as part of the California Proton Therapy Center, Dr. Rossi, also professor and of the California Proton Therapy Center, and Dr. Rose, an assistant professor and also part of the UCSD Department of Urology. So Dr. Mundt is actually the founding chair of the Department of Radiation, Medicine, and Applied Sciences, and also a member of the Executive Governing Committee of the Moores NCI Designated Comprehensive Cancer Center, an internationally recognized academic radiation oncologist whose career has focused on the development and implementation of novel radiation technologies in a wide number of malignancies. He is an author of over 200 journal articles and book chapters, predominantly focused on advanced radiation technologies. Dr. Mundt has edited 3 academic textbooks, 2 devoted to IMRT and IGRT, with over 100 contributors from the US, Canada, Europe, and Asia. He's delivered over 250 invited lectures at cancer symposia and conferences throughout the US, Europe, South America, and Asia, and has been a visiting professor at over 30 universities and cancer centers. Undeniably, we are very lucky to have him and his colleagues today. And so Dr. Mundt, please take it away.
Well, as always, it's a pleasure. Let me share my screen here.
And as he's pulling that up, as always, everyone, please feel free to submit your questions in the Q&A box. Please use that rather than the chat function. And at the end of everyone's presentation, we'll address all the questions together. So thanks, Dr. Mundt.
Well, I'm just trying to get, if I can advance, but I can't go backwards, so I'm going to stop advancing. So it's an honor, as every year, coming to this group. It's been a long relationship with this, and that's why it was so fun to see Lyle's name even though it's in spirit, but it's definitely just wonderful to have this long-term relationship with this group. And we have the honor of kicking off the year talking about radiation, and I think it's going to be a good preview then to Richard Lamb's talk on medical oncology issues, because many things overlap between the two. So today is a format that I started doing a couple years ago. I serve as a moderator. I give a little introduction, just sort of the basics of radiation. And then I bring in different members of our faculty. Today I have the pleasure to have three, Brent Rose, John Einck, and Carl Rossi, and I'll present them one by one in a second. But I do want to point out that our group is much larger than the four of us. So many of you will have interacted with many of our other doctors that treat prostate cancer. And it can be a little confusing because I remember when I presented this first with a small group, someone said, but I didn't see you. I saw somebody else. It's because we have 32 radiation oncologists in our group. And these are the ones around the region that treat prostate cancer. So we work as a group together. And so it depends where you are in the city and what type of treatment you might get. So at the Proton Center, the main doctors for prostate cancer are Carl Rossi, Jim Urbanek, and John Einck. But if you're way down by the border in South Bay, you'll most likely be seen by Sunil Advani. He's a professor in our department that works down there. And so we all function as a group together. And we actually have standards and guidelines for how we treat. And it's kind of exciting. As studies come out and changes happen, we update these guidelines. So by talking to any of our physicians, you actually are talking to all of them, because the genital urinary group, which is where prostate cancer sits, is very in tune and talks to each other and talks about how everything's going to be. So there's a lot of crosstalk between all of our physicians, which means by talking to one of us, you talk to all of us, which is kind of nice. So I'm going to give just a few little basics on radiation oncology in prostate cancer. So there are a couple pillars of treatment for cancer in general, and prostate cancer in particular. There's surgery, there's medical therapy, which is going to be all the the hormonal treatments and chemotherapy, and then finally radiation. So if you think about surgery, you're going to hear the words prostatectomy, taking out the prostate, using robotic modern approaches, sophisticated surgery. In medical therapy, you're going to hear the two main things are hormone therapies, and those are the Luprons and the different modulations of your testosterone level. But there's also chemotherapy, which is very different. So it's cytotoxic or drug therapies that are different than the hormone therapies. And then in radiation, we have two main forms of radiation therapy. We have external beam, where you lay on a table and the machine comes around you. And then we have internal radiation, which goes by the name brachytherapy. Radiation in prostate cancer is nothing new. It's been used for many, many years. And the first patient was actually treated in 1909. So very close to the turn of, the last, 2 centuries ago, actually, back in right after 1900. We treat in two main approaches: definitively, where we use radiation without any other local therapy, meaning without surgery, or we use it as adjuvant therapy, and that just means radiation following surgery. Let's first now look at external beam radiation. So again, there's a machine, there's a couch that you lay on, and the machine, it directs radiation through the air and into your body. And there are two main types of external beam. There's photons, which are X-ray treatment, or there are protons, which are particles. And it's a little confusing hearing the word photons and protons because they differ by one letter, but they're very different forms of radiation, but they're both radiation therapy. The photon radiation, which is the more common type in the world, are what are also called X-rays. And you get X-rays when you get images, you break, you think you break your wrist or something, you go into the doctor and they take an X-ray. That's basically the same thing that's happening with radiation therapy. The only difference is the energy of the X-rays. It's very low energy X-rays for taking images, but it's very powerful, high energy X-rays for delivering treatment. On the right is on the image there is proton therapy, and you can see here. Hopefully you can see my little cursor moving around. That's the couch, and the patient would be on the couch. The thing is, this is a stripped away version. You would never see all this. This would be behind the wall. And so there's a man standing here. And when you're in the treatment room, it looks very similar to when you're in a photon treatment room. The only difference is you don't see this equipment, all this large equipment that's needed to deliver proton therapy is behind the wall. So when we look at external beam, there are different types of external beam, the way we deliver it. When we talk about how you deliver treatment, we use the word fractionation, or it's basically taking something and dividing it up into different doses. Conventional fractionation means we give a small dose of daily treatment over as long as 8 and 8.5 weeks. That is not that common anymore, but that was something that was done throughout much of my career, last 30 years of me in the field, throughout the 90s and early 2000s. Today, when we give treatment, we usually move to something called hypofractionation, where we give less number of treatments, but a bigger dose per day. And that's generally over 5 to 6 weeks. So commonly, a patient today receives on the order about 28 treatments. Years ago, we commonly would give up to 44 treatments, but you're not getting less treatment. You're just getting the less number of treatments, but you're getting more dose per day. So the treatments are equivalent in the amount of radiation effectively to your body. It's just now we deliver them faster. You can then even go even faster in something called stereotactic radiotherapy, body radiotherapy, or SBRT, where we give very large doses over a very short period of time. That's a very exciting approach when it comes to especially the convenience of therapy. And if you only had to have treatment 4 or 5 times, that's great. But the trade-off is you're getting a very large dose per each fraction. And we have to be careful because we have a lot of normal tissues nearby. The rectum, the urethra is right in the middle of the prostate. And so many of us get a little concerned when we give too much per day in too short a time. But the moderate hypofractionation is very safe and is very standard of care today for treatment. Internal radiation, the brachytherapy that I was talking about, is giving radiation from the inside. We implant radioactive pellets, and you can see all the little pellets here in a patient's X-ray. This is the pelvis. This is where the prostate is, and the prostate's full of these little radioactive seeds. Or you can give a temporary treatment where we use needles and we put them into the prostate, and we temporarily deliver internal radiation. So there's 2 forms: the low dose rate, where you get these little seeds that stay in your body forever and basically give off their radiation and become inert and are no longer radioactive. Or you can do it as a temporary treatment where we We place the needles, put the sources in, and then the source comes out through the needle. Here's the radiation therapy process. We start by meeting with you, as any doctor does. You have a visit, we examine you and talk to you about the pros and cons of treatment. And if treatment is decided, we then do something called a simulation. And just like there are flight simulators and in the military where pilots train not actually being up in the plane, but actually being in a cockpit on the ground in a simulator, we actually prepare the treatment in that type of setting. You're on the table, we take images, we make marks, we make measurements, and basically get everything ready to develop a treatment plan. Then the treatment plan is done without you. That's our homework between simulation and the start of treatment. And that's where we plan where the beams come in, how much radiation is delivered there, how do we minimize the dose to normal tissues. And that takes about a week to do. And that's why there's that gap between you getting your mapping session and starting. And then the treatment delivery is done after that. The treatment delivery is meant to be the same every day. So we try to replicate the situation of the CT simulation. We want the patient in the same position. We want to deliver, have the same fullness of the bladder and the position of the prostate. The good news is today we have a lot of technologies that really help us line up the patient, focus the beam on the prostate, and that's called image-guided treatment, which really helps us have very accurate treatment delivery. So here's the clinic visit where we talk with the patient. Then we do a mapping session with the CT simulation. You have the patient on the table, and then we take x-rays. Then we work on the computer to define, here's in red where the prostate is, the rectum is back here with blue, and in front is the yellow, the bladder. And we, in this image, you can see the hip bones over here. And so this one, we want to maximize the dose to the red, minimize the dose to the blue and the yellow. And then finally, we deliver the treatment either with photons, with a machine like this, or with protons. And that involves positioning the patient on the table, imaging every day to make sure the treatment is accurately focused, and then meeting with the physician on a weekly visit. And that's often called an on-treatment visit or an OTV. You'll hear people say, do you have your OTV today? And that's what they mean. It's the meeting with the doctor to talk about how is treatment going. If you're having any side effects, we can use medications or we can modify the treatment to help with the side effects. And then just answer any new questions that come along. So definitive treatment for prostate, or in this prostate cancer, and this is again without surgery when we talk about definitive treatment, EBRT, or the external radiation with either photons or protons, is most common. You can give it conventional number of treatments, hypofractionation, or SBRT. The most common is hypofractionation. Conventional used to be, but no longer. Brachytherapy could be with the permanent, the seeds that are permanently put in, or temporary. And these are equally common, but it's over time, probably HDR is becoming more and more popular. If you look at, we can also combine external beam and brachytherapy, where we put together either photons or protons with a boost using brachytherapy. And that the external beam is usually given conventionally because we don't tend to like to go hypofractionated and then add a boost of brachytherapy. We want to be a little more gentler on the normal tissues. And as I was referring to with Richard Lamb coming next month, often we combine the radiation with hormonal therapy like Lupron. And the reason for that is it actually can make the two work better together. So it's a 2 + 2 = 5 kind of thing. but we reserve that for patients with higher PSAs or higher Gleason scores. So many of these things are going to be talked about today. John Einck is going to talk about how do you sort of choose between a lot of these, if you're going to have radiation, how do you choose between many of these different modalities? Brent Rose is going to talk about concepts of what you have and, what's a PSA and, what's going on with sort of the basics of prostate cancer and how you should approach it. And Carl is going to talk about sophisticated proton approaches to radiation. There's also giving radiation after surgery. Sometimes you have surgery, we need to give radiation because of a rising PSA or a margin that had cancer left behind. Again, we can do that with either photons or protons, and that's usually more conventionally fractionated because now the tissues have been exposed to surgery, so we tend to want to be a little more gentle on those tissues following surgery. There's no role usually for brachytherapy, because there's no prostate left behind. And we usually don't do things ever like hypofractionated, and definitely not SBRT, because the tissue now could be exposed to the side effects of surgery and the side effects of radiation. So we have to be careful. And then, of course, if there's no prostate, we can't combine external and brachytherapy. We use two terms that often sound, pretty awful. The word salvage is kind of an unpleasant term, but what that is giving treatment in patients who have a rising PSA. So you've had surgery, and then a year or so later, if the PSA starts rising and we give radiation to where the prostate was, we're salvaging that awful term, but we're giving radiation to now try to get rid of the cancer that's growing where the prostate was. And salvage radiation, it may be combined with Lupron and other hormone therapy, but not always. So here are going to be the three speakers. So why don't I present them so we don't have to go back and forth with screen sharing. I'm just going to present all three, introduce them all at a time, but it's first going to be Brent Rose. He's assistant professor in our department, and he is jointly appointed in the Department of Urology. He does a lot of research with that department, so he's actually has two bosses. He has to put up with me and a urology chair. He did his residency following his medical school at UCSD at Harvard University, and then came back here. He has multiple research grants from the Department of Defense. The Department of Defense is a wonderful organization that looks at prostate cancer and funds a lot of research, and he has several large grants from the Department of Defense focused on prostate cancer. He publishes extensively, and he is very interested in issues around the use of finasteride in prostate cancer patients, the cognitive effects of hormone therapy, many of the things that patients are very interested all the time. He also works in a high-risk prostate cancer clinic at UCSD together with our local medical oncologist, Ronna McKay, who many of you probably know. She is sort of the Richard Lamb, type of doctor that works with us at UCSD. Aditya Bagrodia, who is a urologist, and Brent see patients together in the multidisciplinary prostate clinic. Then there's John Einck. He's a professor in our department. He's our section chief for prostate and genital urinary cancers. He's also the director of our prostate brachytherapy program. So he's one of our best trained doctors in that area. He did his training at the University of Washington. University of Washington is the mecca and reestablished the use of brachytherapy in prostate cancer over the last generation. And John came from that experience and trained with all the leaders in that revolution, who are all retired now. So now it luckily passed that experience on to people like John. He's an expert in the application of all modalities, IMRT, IGRT, SBRT, and works in protons with Carl together. They have clinics at the Proton Center. He's been a top doctor multiple years in the San Diego Magazine. And then finally, Carl Rossi, he's a professor at UCSD. He did his residency at Loma Linda, which was the first hospital-based proton center in the world. And actually, he treated the first prostate patient as a trainee at Loma Linda in 1990. And ever since then has been focused on the treatment of prostate cancer with proton therapy, has treated over 10,000 patients. We've been saying 10,000 for several years now, so it's probably grown a lot more than that. But over 10,000 patients with proton therapy. So he's arguably one of the most experienced, or the most experienced physician in proton therapy for prostate. So I'm going to now unshare my screen. So Aaron, I'll pass it back to you. Or should I just pass it right to Brent?
Oh yeah, go right ahead to Brent.
Okay.
Well, hello, everybody. Just a quick check. Can everyone see my screen okay and hear me okay? Excellent. All right. Well, thank you so much for having me. It's always a pleasure to come to this group. I've been doing it for, I believe, 4 or 5 years now, and it's always fun. One thing I miss from when we were doing it in person is we used to always go around the room and just have everyone raise their hands, and they'd say, "How long have you had prostate cancer?" And I was always surprised how many people have been very recently diagnosed, only a couple months since they've heard that they had prostate cancer. But we continue to go around the room a year, 2 years, 5 years, 10 years, even up to 20 years. And it was fun to see how many people have had prostate cancer for a long time. And really it was kind of nice to see for the people who are newly diagnosed that prostate cancer can be something that can be cured or at least managed for a very, very long time in the large majority of the guys. So that was always great to do and fun experience. But again, there were always a fair number of guys who were recently diagnosed, still trying to learn all of the information about prostate cancer. And that's also why I like this group, is because it's really about getting informed, really learning about prostate cancer so that you can make the right decisions for your specific case, because everyone's a little different. Every cancer is a little bit different depending on, where it's, how aggressive it might be, where it might have spread to, whether the treatment options are right for you based on your own personal circumstances, whether that be your age or your interest in, quality of life and side effects and things like that. So there's no one right answer for prostate cancer. So really what you have to do is just get informed and learn as much as you can about it. And that's why this group is really great, because it really helps to educate everybody. But a new diagnosis is scary. It's also, there's so much new terminology and information, a lot of words you've never heard before, a lot of technologies and techniques. And it just feels like when you're first diagnosed, it's so hard. You almost feel like you need to get a PhD in prostate cancer before you can make any of these real decisions. So that's why we really want to help you just to understand your case as much as possible. And realistically, some of this is even harder now because of the pandemic, because you might not be able to easily get to see your doctors, and they might want to do it over Zoom or the phone, and you're not really sure that you're understanding what they're saying, or you don't have access like you might like. Often we've not been able to have our partners and spouses in these conversations. And that can be hard because it feels like you don't have someone there to help support you while you're learning all this information. And then sometimes services like biopsies or surgeries or things like that might have been temporarily halted. And then that just makes you worried. Am I missing out? Am I waiting too long? Is something going to happen while I'm waiting for the coronavirus? Or maybe on the flip side of that, can I wait longer because of the coronavirus? I don't want to expose myself. Can I avoid hospitals? Can I wait longer? And so all of this is just such new information to a lot of people that I just wanted to go through a lot of the basics. And, we see lots and lots of guys with prostate cancers, and you end up seeing a lot of the same questions. And so if we could just sort of right off the bat introduce people to prostate cancer and address a lot of the questions that people are going to have, we think that that could be pretty useful. And another thing we find is that people will often assume certain things that are not actually true. So I'd like to point out some of the things that people think might be true, but might not actually be. So just to start out with prostate anatomy, can everyone see my cursor? Yeah, okay. So if you haven't seen this before, I apologize to some of the guys who've been around for 20 years. This is going to be pretty information they've already heard, so I apologize for that. But for those who are new, just want to go through some of these things. So the prostate sits right here. If you imagine that you're standing up, looking to the side, and so this would be your stomach, and this would be your backside. Your prostate sits right here, right between your bladder, which holds the urine that you're going to pee, your penis, and then your rectum, obviously where the stool is. And important things to point out here is that the tube that you pee through goes right through the middle of the prostate and out to the penis. This seminal vesicle here is also an area where cancer can go to. That's something that we always think about. Okay, and so this always brings up a few questions that people ask. If you're 65, 70 years old, you're probably getting up a couple times a night to pee. Is it because of the cancer? You just got diagnosed with this cancer. Is that what's causing you having trouble urinating? The answer is probably not. The large majority of guys of a certain age just have to get up to pee a couple more times. And that's mostly because the normal prostate itself is just starting to block this tube a little bit. Cancers usually pop up in the back of the prostate, not in the front of the prostate where this tube is. So most of the time, you can't feel the prostate cancers at all. That's not always the case. In very advanced cases, they can be pressing on the urethra a little bit. And so that's not always true. But for the large majority of guys who are noticing issues with urination and have prostate cancer, those are two completely unrelated issues. Similarly, erections just diminish with age. So often if you're starting to notice changes with erections, but you also have the prostate cancer, you might connect the two and think that the cancer is causing that. It usually doesn't do that. Again, in rare cases where the cancer is growing out into the neurovascular bundle, it can. But the large majority of the time, that's just a natural aging process, not actually related to the prostate cancer itself. And then a lot of guys wonder, what does the prostate actually do? Is it just sitting there waiting to get cancer? Not exactly. What the prostate and the seminal vesicles do is actually create the fluid that comes out when you ejaculate, when you have a sexual orgasm. And so that fluid actually has a function, and the function is really to carry the sperm to the egg in the female to help impregnate the female. So there is an anatomic function of the prostate. But its location leads to a lot of the specific questions about treatment and things and side effects of treatment. So we have to know where exactly that is. Okay. So most people have heard of the term prostate specific antigen, or PSA. So what that is, that's just a protein that's made by the normal prostate and potentially prostate cancer if you have prostate cancer. And it's just a simple blood test that we can measure in the blood. So we can always just take a little bit of blood and detect how much PSA is floating around in the blood. That's used for a couple different scenarios, and how useful it is depends a little bit on where we are in this cancer continuum. So the large majority of guys out there are at some point going to get a PSA test for screening for cancer, trying to detect, do you possibly have prostate cancer? Okay. Once you're diagnosed with prostate cancer, we also want to know, how aggressive is this? How likely is it to spread or cause big problems? We call that risk stratification. And sometimes if you're diagnosed with an early form of prostate cancer, we don't actually want to treat it, but we want to keep a close eye on it. We call that active surveillance. And so we'll use the PSA test to just kind of monitor the cancer. And then also, if you're actually treated for the cancer, we want to make sure that it's gone and it's not coming back. So we use the PSA test to monitor for recurrence. There's lots of different uses of this PSA test. And everyone wants to know, what is a normal PSA? And the problem is, it depends. It depends where you are on that continuum and the context behind it. But if we remember that the PSA is coming from both the normal prostate and the cancer, if you have it, there's not really a normal level of PSA. Often we'll say that a PSA above 4 is high, and then they might want to send you for a biopsy based on that. But that doesn't mean that you necessarily have or don't have cancer. About 15% of guys who have a PSA that's less than 4 really do have a prostate cancer. We just haven't detected it. But even if your PSA is all the way up to 10, half the time there's also no prostate cancer there that we can detect. So it's not a perfect test for cancer screening. We wish we had a better test that said, yes or no, you have prostate cancer, yes or no, we need to treat this. But we don't, unfortunately. But the PSA is one of the better tests that we have. And so we do use a lot. So it's important that you understand what PSA can and can't do. But there are some problems with the PSA test. And a lot of it, like I mentioned, the PSA could be coming from the normal prostate, or it could be coming from the cancer. But it also fluctuates a fair amount. So as the prostate gets bigger, as guys age and prostate just generally gets bigger, the PSA usually rises up with it. So a 30-year-old gentleman might have a prostate that's 20 cc's and the PSA might be 0.5, and that could be normal. But a 75-year-old gentleman might have a 75 cc prostate, and a PSA of 7 would be normal for him, not indicating prostate cancer. So again, there's not really a definite normal to what the PSA is, particularly before you get diagnosed with prostate cancer, but it does provide information. Also, sometimes the prostate just gets irritated or inflamed. Sometimes we call that prostatitis or various other terminologies, and that can just make the PSA falsely elevated for a temporary amount of time. So there are a few other things that can falsely elevate it. If you have sexual activity or recent ejaculation, your PSA can be a little bit higher. If you've recently had a digital rectal exam, somebody actually examined your prostate, even just riding a bike actually, because it puts pressure on the prostate. All of these things can temporarily elevate your PSA. And so a lot of guys who have had PSAs in the past will notice that one year it was 5.5 and the next year was 6.5. And then the year after that, it went back down to 5.5. And you try to infer, oh, maybe my diet changed it. Maybe, something happened, but it just fluctuates a lot. So we have to remember that PSA is kind of a noisy indicator and will fluctuate a little bit. Once we know that you have prostate cancer, the PSA can be very helpful. And also the higher the PSA is, the more we think that that is coming from the cancer. So it gives us more information when the PSA is quite high. So if we know you have prostate cancer, it helps us to decide how aggressive do we think this specific cancer is. And the broad groupings are, if it's less than 10, we think that that's pretty favorable generally. If it gets a little higher in the 10 to 20 range, that starts to tell us, well, we think that there's a fair amount of cancer in there. We think we should take this serious. And if the PSA is over 20, then we are more worried that the cancer could spread and could do bad things if we don't be very mindful of what's happening. And sometimes it could indicate that the cancer already has spread. So we might want to do more imaging and things like that for the higher PSA. Okay. And then often when the PSA is a little bit elevated, often again, that PSA 4 cut point tends to be when people are referred for biopsies, but again, that's not a magical number. We'll send them for a prostate biopsy. And so a lot of guys here have already had that. This is probably one of the more unpleasant experiences you've had in your life. But what they're really doing is they're putting this ultrasound probe into the rectum. So they're coming from behind the prostate, and they typically will do 12 biopsy needles. And it's really a sampling. They'll take 2 from the top right, 2 from the top left, 2 from the middle right, 2 from the middle left, 2 from the bottom right, 2 from the bottom left. So you're really sampling the prostate. But I'm emphasizing the word sampling because you can miss a little bit more aggressive cancer. In about 30% of cases, there can be a little more prostate cancer there than we expected. And in particular, we think about the front of the prostate over here and right around the urethra right here. If you can imagine the needles are coming from behind, it's hard to get all the way to the front of the prostate. And also, if the urologist puts a needle into the urethra, you're going to end up with blood in the urine for a while, and it can be quite uncomfortable. So people try to avoid the urethra. So there's certain areas where we know that we can sometimes miss prostate cancer. So we want you to be aware of that. So I just want to show you this picture before we go back to that staging system. Often if we're worried that there might be more prostate cancer there than we expected, we'll have someone get a prostate MRI. And you can see in this picture here, it's a little hard to interpret, but this is the rectum, this is the prostate here. And this black thing in the front of the prostate is a prostate cancer that wouldn't be very well sampled from putting needles in from this side. So often a prostate MRI gives us more information about potentially how aggressive the cancer might be. Okay. And then we always end up talking about the Gleason grading system. And part of that is because it's very confusing. And so people are always so confused. Is it a 3, 3, 6, 7, 3 plus 4? And so This was the Gleason scoring system is an older system that was designed a long time ago. And you end up getting 3 different numbers. The first number is the most common pattern within the cancer that they see, and they grade that somewhere between 3 to 5. And then the second number is the second most common pattern that they see, and again, they grade that from 3 to 5, 3 being the least aggressive, 5 being the most aggressive. And then they add that number up to get you a summary score. The problem is how much of the individual components does matter. So a 3 plus 4 is actually better than a 4 plus 3, even though they both add up to 7. So people realize that this is horribly complicated and confuses people. And the other issue with it is it essentially starts at a score of 6 and goes to 10. But someone hearing that they have a score of 6 thinks that that's bad, because what about 1, 2, 3, 4, and 5? I'm already at the 6th rank here. But that's actually not true. 6 is the lowest grade cancer you can have, and 10 is the highest grade cancer you could have. So they decided that this system is just entirely too confusing. They wanted to make it simpler to convert to the grade grouping system. So often you'll hear about the grade grouping system. Unfortunately, we haven't fully transitioned over, so sometimes you'll hear about both different systems that get even more confused about that. But the grade grouping system was designed to make it more simple, where the grade of the prostate cancer, meaning what it looks like under the microscope, is just graded from 1 being the least aggressive to 5 being the most aggressive. And we do like to transition over to the grade grouping system. And then we broadly categorize that again with 1 being the least aggressive, 5 being the most aggressive, and then 2, 3, and 4 being somewhere in between. And this is the MRI picture that we showed. Sometimes if we want to be sure that we've sampled the prostate as much as we possibly can, we'll get an MRI to confirm that the biopsy needles went where we wanted to go and that we weren't inadvertently missing something. We also use it to see, is the cancer spreading? Is it going beyond the outside of the prostate? Is it growing into anything nearby, like the neurovascular bundles or to the seminal vesicles or things along those lines? Because those can be important to know for which treatments you might choose. You can also use it sometimes for focal targeted treatments. And this is a question that we get all the time. And it's a really important question to know, because people will often say, well, look, I can see the prostate cancer. It's right there. Let's just treat that thing. Let's freeze it with cryotherapy. Let's hit it with SBRT and then not treat the rest of the prostate. In theory, that would be great because you could avoid the urethra. You'd be away from the rectum. But the problem is that we know that prostate cancer is usually multifocal. Usually means that there's cancer kind of throughout the prostate. Yes, there's going to be prostate cancer here, but there's also going to be a little bit of prostate cancer over here, a little bit over here, a little bit over here. So if we just treat this with any of those pure focal techniques, we often see that the cancer just come back at a different side of the prostate. That doesn't mean that we don't want to know this information, and more we are targeting the whole prostate and then increasing the radiation dose to what we think is the most aggressive part of the prostate cancer. But we still don't typically think that the MRI is good enough to tell us that we can only treat one part of the prostate. And then when we know that we have a prostate cancer, we know what the Gleason score is, meaning how aggressive does it look under a microscope, how likely is it to spread. We also have the PSA to quantify how aggressive we think it is, how much cancer do you think it is. Then we want to look for it with imaging. And so the most likely spots where it can spread to is the lymph nodes on the side of the pelvis, or even up into the abdomen, or the bones. And so historically, the standard imaging was a CT scan and a bone scan. Those are okay, but they're not great. You can see here in this picture, this is a CT scan, and this little guy right there is a lymph node. It'd be really hard to say on that CT scan that that's an involved cancer lymph node. If it gets bigger, 2 or 3 centimeters, and we say, oh yeah, that's an involved lymph node, I can definitely see it. But often prostate cancers in lymph nodes don't make the node that much bigger. So you see a node like that and you say, well, I'm not sure exactly what that is. Maybe it's nothing. Cancers in bones can sometimes be obvious on a CT scan, like this little spot here, but often they're not. The other problem with the bone scan, as anyone who's had a bone scan will know, is it usually says there's something in the hips or the back, and it's probably arthritis, but we're not really sure. So you get a lot of these indeterminate answers with the bone scan, so that's not ideal. But now one of the new tests that's available, which we're really excited about, and a lot of people might not have gotten them yet, but they are now FDA approved and paid for it at almost all places, is the PSMA PET scan. And so you can see on this image how much more obvious that lymph node is on that PSMA PET scan because it's glowing bright right there. Similarly, the bone spot is more obvious. You can see it growing right there. So this can be really, really helpful to find subtle, small little bits of cancer spread that we want to be aware of. Okay. So if you haven't had a PSMA PET, maybe that's okay if you have a low-grade cancer. But whenever you are getting imaging for your prostate cancer, you might ask, would a PSMA PET be helpful in this case? Okay. And then the question we often hear is, what stage am I? You know, most cancers you hear stage 1, stage 2, stage 3, stage 4. We don't typically use that terminology in prostate cancer, which can get confusing because you leave from the consult and they said, I don't know, they said it was risky, I'm not sure what's happening. So just to try to boil this down to the system that we typically, the way we talk, if we want to think about, one, has the cancer spread? Has it already grown outside of the prostate into bones or lymph nodes outside of the pelvis? If so, we call that metastatic. And so that is managed in a totally different way. Sometimes if the cancer was involving lymph nodes, we'll call that regional, and that's a little bit in between a localized or a metastatic, but typically we're still trying to aggressively treat these. The bulk of cases end up being called localized prostate cancer, and that includes low risk, favorable intermediate, unfavorable intermediate, and high risk. So there's kind of a word salad there with lots of different terms. But realistically, we think of that as localized prostate cancer, meaning just isolated to the prostate itself. And then that risk evaluation, whether low, high, is just how likely that cancer is to spread at some point. But it's a little confusing because high risk sounds scary, but as long as you're in the localized category, you're still in a very good situation. Most of these are still curable. Okay. But it does help us to kind of risk stratify patients on how much treatment that they're going to need, how aggressive we need to be. And so these are the sort of terminologies that we use. Often we also ask, should I get a genetic test? And if so, which one? And so broadly speaking, there's actually two main types of genetic tests that you should be aware of. One, and unfortunately, these terminologies are not very clear. And so it's not intuitive when you hear that they think you should get a germline genetic test. But what germline means is that's your genetics. That's the genetics that came from your parents and that you passed down to your children. Okay. And we're really looking for, do you have a specific mutation that might have led you to get this cancer in the first place? And if you did, that would be important to know because you might have passed on that gene to your children. Okay. And so now officially anyone with high risk or metastatic cancer is recommended to get a germline genetic test to see if there was a predisposition to having prostate cancer. And sometimes these genetic predispositions predispose to multiple different types of cancer. So for example, one of the types of mutations is a BRCA mutation that can cause prostate cancer in men, but can also cause breast cancer in women. So even if you don't have sons, that doesn't necessarily mean that you don't want to do this germline testing. So that is something to be aware of. Often when we think of genetic or genomic testing, what we thought that we were talking about is, what about the tumor? What are the genes in the tumor and how does that affect me? So we call that somatic testing, is differentiating from germline testing. And so that's where we actually take a piece of the tumor, send it off to a lab and say, how aggressive is this cancer? Is this specific cancer? And potentially, are there specific gene mutations that we can target with medications and things along those lines? So we're doing somatic testing more and more frequently, but it's still not a standard that we do for most cases of prostate cancer. And the reason is because the PSA, the Gleason score, and the staging give us a lot of information about how aggressive the prostate cancers are. We generally have a pretty good sense of what the right treatments are, even without the genomic testing. But in cases that are sort of on the border where the doctor is talking to you about hormone therapy, but you're not sure if you really want to have the hormone therapy, sometimes a Decipher test or something like that can help you to know a little bit more information. So it might be something to ask about, but it's not useful in all cases. Okay. And then just a list of common questions that we hear people ask all the time. You know, I just saw my urologist, he says, I need surgery or I need radiation, I have to have it right now. but I don't really know what's happening yet. I don't feel comfortable with that. Is that okay? How urgent is this? They got me on the books in the OR in 2 weeks. What should I do? Don't worry. Prostate cancer is a slowish growing cancer. So you have the time to wait. You have the time to get informed. Talk to other doctors. Make sure that you have all the information that you need before you make any big decisions. And that's a big part of this group, is just getting informed, because you do have the time to get the information that you need. So while this is a serious disease and sometimes we want to treat it aggressively, you always have the time to make sure that you understand the situation and that you are making the right treatment for you. The question is, who should I see? Almost everyone will have seen a urologist because they typically do the biopsy, but you should always ask to see a radiation oncologist as well, because there are different options. Surgery is a great treatment for some, but not for everyone. And so if you don't hear from a radiation oncologist, you might not know what other options there are out there. And sometimes people might want to see a medical oncologist as well. Medical oncologists are the doctors that usually prescribe hormone therapy or targeted therapies, and in rare cases, chemotherapy. Not that common, but sometimes. These doctors are great doctors too, and they can add a lot of value. If you've met with your radiation oncologist and you've met with your surgeon, maybe they're talking about hormone therapy, but you don't fully feel like you understand that aspect, ask to see a medical oncologist too. Again, there's no major rush. You can almost always have the time to do it, and more information is usually good. We talked a little bit about, do we have to treat the whole prostate? Unfortunately, we still do think that we need to treat the whole prostate. We can certainly talk about boosting areas and giving a little more treatment to one area, but again, prostate cancer is usually multifocal. And then a couple general questions, and this is sort of the crux of the discussions that you're going to have with your doctors. How will this treatment affect my urination, my sexual function, bowel movements, and really even identity? A lot of these things are wrapped up in who we are and who we think we are. And so sometimes that can be hard to wrap your head around, the changes that might happen to your body through treatment and things along those lines. So you want to make sure that you know what is going to happen. What are the changes to your urination? What about sexual function, bowel movements, and things along those lines? Make sure you talk to people. Make sure you talk to patients who have been through surgery, radiation, brachytherapy, all these different things. Make sure you've talked to those specific doctors and ask specific questions. When you say my sexual function might come back, what are my chances? How likely am I to need pads after surgery? And get specific numbers. They may not offer specific numbers, but generally they know them. And so they'll give them to you if you ask. Another thing that we see frequently is that this is a scary time. All these treatments do strange things to our bodies and make us feel weird. Depression is a very common thing to go along with any cancer diagnosis, but particularly prostate cancer, particularly when we're manipulating hormones and changing erectile function and things like that. So this is normal. Don't think that you're abnormal if you want to talk to somebody about some of the emotional challenges you're facing. So this is a very normal thing. Feel free to ask. Okay. And so that concludes my talk. I think we'll pass it over. I believe Dr. Einck will be coming next. So I'll stop sharing.
Thank you, Brent. So let me share my slides here. I want to say, like the other speakers did, that it's always a pleasure to talk to this group. I think I've been doing it for 8 to 10 years now, and this is a group of guys that are helping a lot of other guys and their wives and significant others, helping other folks who are just diagnosed with prostate cancer to make the right decisions about their treatment. And I always have to applaud you guys for the service that you do. I also want to thank Dr. Mundt and Dr. Rose for giving such a nice introduction. It'll make getting through my talk a little bit easier. So what I wanted to talk about is, I do a lot of different treatments for prostate cancer. I treat patients with protons at the California Proton Center. I use IMRT at UCSD. I treat with brachytherapy. I don't do a lot of stereotactic body radiation therapy, but it's something that we are doing at UCSD, and it's always an option. So as someone that has all of these tools available for you, how do I decide what treatment is right for you and how to individualize radiation therapy for prostate cancer? Dr. Rose said there's no right answer about treatment, and that is absolutely true. And so I made the comment, how do I decide what the best option for you is? And the answer is I don't. I go into the room after reviewing your records, and the idea that I have going into the room and the plan that I'm going to recommend almost always changes based on what you want and your goals for treatment, what kind of side effects you're willing to live with, which kind of side effects you're not willing to live with, how many weeks you're willing to come in for radiation therapy is always oftentimes a factor with treatment. So I wanted to use a representative case to show how I make the decisions that I do with my patients to determine the right option for them. So let's say this is actually a patient I saw last year, 59-year-old man, presented with a PSA of 14.4, skipped a few years with getting PSAs, and this year was markedly elevated. And Dr. Rose already told you that over 50-50 chance of him having cancer if he has a biopsy with PSA over 10. So also had a palpable nodule. So when they did the digital rectal exam, he had an abnormality on one side and had biopsies done showing a Gleason 4+4 adenocarcinoma. So again, Gleason's score is confusing, but if we distill it down to the Gleason grade group, this is a patient who's grade group 4 on that scale. He had 6 out of the 7 biopsies on the right positive and 0 out of the 7 on the left. And his prostate was pretty small at only 25 cubic centimeters. So again, the options that I think about before I go into the room with the patient are I could treat him with external beam with IMRT or protons. I could use brachytherapy. My brachytherapy of choice is LDR, but could also use HDR. And I'm glad Dr. Mundt described sort of the differences between those. Or we could treat the patient with gamma knife type of radiosurgery known as stereotactic body radiation therapy. I think someone already went through risk stratification, but it's important whenever I'm talking to a patient for me to risk stratify the patient first. This patient falls squarely into the category of high risk disease because of the Gleason 8 cancer. He also had an MRI of the prostate. You can see on the right here, I put an arrow to point out this nodule, this dark circle on the side of his prostate gland is actually a prostate cancer that's bulging the capsule. And this MRI is actually worrisome for extra capsular spread of prostate cancer. His lymph nodes were otherwise normal. Seminal vesicles were normal. So how do I counsel this patient regarding treatment options? Should he have surgery? Is there one option of all these options that we're talking about that are better than others for him? So this is a complicated chart. There's an organization called the National Comprehensive Cancer Network that a group of experts gets together and determines guidelines for what are the appropriate treatment options for patients diagnosed with various cancers. These are the March 2022, so hot off the press, most recent NCCN guidelines showing that in this patient with high-risk prostate cancer, greater than 5-year life expectancy. So if someone's not healthy and we think they're going to die of something else in the next 5 years, of course, our treatment recommendations are going to be different than if they have over a 5-year life expectancy. And this says we could use external beam radiation therapy with ADT. It says we could use external beam radiation therapy with brachytherapy and ADT, external beam plus ADT and chemo, or external beam plus sort of super duper ADT with ADT and abiraterone for this patient. So a lot of different treatment options, and the EBRT has a little footnote on it that says we could use protons, we could use IMRT, or we could use SBRT, which is a 5-fraction treatment, which some of you might think of as gamma knife type treatment. So a lot of different options for this patient that are appropriate. What you do, or he could have radical prostatectomy with lymph node dissection. So you don't see any partial prostate options on here. You don't see any HIFU. You don't see cryo. You don't see radiofrequency ablation. So these are the options that a group of experts have gotten together and decided are most appropriate for this patient. When I sit down with a patient, particularly high-risk patients, I like to go and pull up this nomogram. You can find it at the Memorial Sloan Kettering website, and the web address is at the bottom here. But it really tells us if this patient had surgery, what is the likelihood of cancer extending outside the prostate gland? What is the likelihood of lymph node involvement, of seminal vesicle involvement? And then finally, what is the chance that surgery is going to cure this guy? And what is the likelihood he's going to die of prostate cancer? So this is how it kind of spits out the results. It says the good news here, this guy has a pretty favorable high-risk cancer. His likelihood of surviving 10 years and not dying of prostate cancer, or specifically not dying of prostate cancer in the next 10 years is 99%, and at 15 years, 97%. So I don't think we have to make decisions here out of fear that this patient's going to die of prostate cancer, but clearly this is someone who's going to have problems from it if we don't treat him. But look at this part. If we do surgery on this guy, the likelihood that surgery is going to cure him at 5 years is 42%, and at 10 years is 27%. So I'm not saying from these numbers that it's wrong to do surgery on this patient, but I think a patient who chooses surgery in this situation needs to be realistic that the likelihood of them still requiring radiation after surgery is probably about 50%. And in my mind, I'm not sure that I would want the combined side effects of both surgery and radiation, but this is always a decision that patients have to make. And the reason surgery doesn't work so well is that the likelihood of the cancer being confined to the prostate is only 22%. And the risk of lymph node involvement is 23%. So it's hard to remove all of that cancer surgically, and hard to not think about the need for radiation afterwards. So in my mind, that's a patient that I'm going to counsel, yes, if you want surgery, you need to be realistic that there's a high likelihood of needing radiation. But more likely, I'm going to recommend one of these different radiation treatment options. So in most men, there are a number of options that may be appropriate. As Dr. Rose said, no right answer. But often when I'm looking at a patient's chart and their health and their urinary symptoms, oftentimes I come up with options that I think might be better for them than some others. So how do I do that? In this patient, I offered 12 months of ADT. High-grade cancers need ADT, and Dr. Lamb will talk to you about ADT next month. I recommended 5 weeks of proton therapy to the lymph nodes and the prostate gland, followed by a prostate seed implant using I-125 seeds. And those of you who've been attending this meeting for years I'm sure are thinking, oh, here Einck goes again, talking about brachytherapy. Isn't brachytherapy dying? There aren't many people that do it. Aren't the seeds going to migrate? And I will just say in response to that brachytherapy is still a very important treatment option for patients with prostate cancer, and I'll show you some data on that in a second. Seeds don't migrate in 2022. They're all stranded and attached to one another. And no, it's not dying. It's still done at many academic centers throughout the world. This is a group of patients that we treated in the sort of the pre-brachytherapy days when we weren't doing as much brachytherapy on high-risk patients. And I just threw this in here because we had 183 patients, and there clearly is a group of patients with high-risk disease that are more favorable. There are those patients who only have one high-risk factor. So it could be Gleason 8 patient with a PSA under 10, who doesn't have over 50% of their biopsies involved. Those patients sit here on this blue line. They have an excellent long-term cure rate with the combination of ADT and external beam radiation therapy. So that external beam is non-denominational. It doesn't, these were all treated with IMRT, but this could be protons or IMRT. But here are patients who have two high-risk factors. So like the patient I'm talking about, in this case that I've presented, he has a PSA over 10 and he has Gleason 8 cancer. He has two high-risk factors and would do significantly worse if I didn't include brachytherapy as a component of his treatment. So I offered, again, as speaking to the 5 weeks of proton therapy, you know, Dr. Rossi is going to talk a lot more about protons, but I can just tell you that it's much easier to get a good dose to the lymph nodes when I'm treating lymph nodes in these high-risk patients without giving radiation to their small intestine. And what that means to me is they don't get diarrhea during proton therapy. About 15% of patients get diarrhea during IMRT. So I know that I'm giving a lower dose to the intestine with proton therapy, and that's going to translate into a lower long-term risk for those patients. Any of you that have gone on the internet and looked for information on protons have seen this chart. It shows that with X-rays or photons, the radiation goes into the patient and it comes out the other side. So we have to trick this kind of radiation with complicated computer algorithms to get a good plan. Protons, I think, for patients are a little more intuitively, a little more understandable, because protons go in, they build up to a maximum dose within the target, hopefully, and then the dose falls off and there's no measurable radiation on the other side of the patient. So it's technically a little easier to get a good plan, but when I'm treating lymph nodes, I don't have to worry about giving radiation to all of the tissues in between the lymph nodes. Dr. Rossi probably mentioned this too, not all proton beams are the same. At California Protons, ours has intensity modulated proton therapy, which gives us a much better ability to sculpt the dose of the radiation around the lymph nodes and prostate while avoiding normal tissues. An example of two plans on the left here is proton therapy, IMPT specifically, and on the right is IMRT. And I'm sorry, the curves aren't the same colors here, but you can see the lymph nodes sit along the sides of the pelvis, and giving a dose of radiation with protons, I'm able to give a nice dose to the lymph nodes, but you don't see any of these colors in between the lymph node volumes. And that tells me I'm literally giving zero dose to the small intestine, the bladder, and the rectum. In the IMRT plan, this red curve here that I'm tracing with the pointer is 50% of my prescription dose. So with IMRT, I do give some low dose radiation to the bladder, the small intestine, and the rectum. And that's why I prefer protons when I'm treating lymph nodes. Down close to the prostate and seminal vesicles, the plans look very similar. There's a little more low dose radiation going out into the periphery here with IMRT, but in most cases, that's not terribly significant. In young men, guys in their 50s with prostate cancer, I think we can really make a case that protons may be better for them. There is less scattered dose of radiation around the pelvis and perhaps a lower risk of them getting cancer from having radiation therapy, 20, 25 years in the future. I will tell you, though, even with IMRT, the risk of patients getting cancer 20, 25 years in the future is about 1 in 2,000. So not at high risk with either form of therapy. And then finally, why did I recommend a seed implant? Is it just because I love doing them? Yes, I do love doing seed implants because I love seeing these patients a couple of years later when they're doing so well. But here's the concept of combined therapy. So we'll give a proton therapy or IMRT to the lymph nodes, and then follow that with either low dose rate brachytherapy boost or high dose rate brachytherapy boost. And the reason I feel so passionately about offering brachytherapy to these patients is I showed you our UCSD results. Patients who are unfavorable have about a 60% long-term cure rate with external beam plus ADT. And I don't think that's high enough when I have data like this. This is the Ascend RT trial that was done in Canada. published in 2017. And you can see patients had pretty high doses of external beam radiation. They randomized patients to 78 gray of external beam radiation or 46 gray of external beam plus a seed implant afterwards. And they randomized 400 patients to half had the brachytherapy, half didn't. At 3 years, the results were identical, 94% chance that they were cured. At 5 years, we're starting to see some separation, 89 and 83%. But look at the 9-year results. 83% of those patients, and these are patients with high risk or unfavorable intermediate risk. This is an unfavorable group of patients that had an 83% 9-year cure rate versus a 59%, very similar to our UCSD data, if they had ADT and external beam radiation therapy alone. So this is where I want my patients to be on this 83% group. I don't want them to be down here where they only have a 60% chance of cure. So again, this is why I recommend brachytherapy. There's a price to pay. The dose is much higher with this combination treatment. That's why I think it works better. There are higher urinary risks when I add brachytherapy, notably urinary stricture, which has to be repaired surgically. And there was a 7% risk of urinary stricture in this group. So greater than over 90% of patients did fine, 7% had strictures. So not every patient's a brachytherapy candidates, although I want my patients to have brachytherapy. If they have severe urinary symptoms, they have trouble peeing, they are waking up 3-4 times at nighttime to pee, they have a really weak urinary stream, they have a long-term history of going to the urologist for urinary issues, those are not patients that are going to do well with brachytherapy. I tell my patients, you won't like me very much 3 or 4 months later. Patients with large prostates, it's technically hard to get seeds to all parts of the prostate because the pelvic bones get in the way if the prostate is much over 50 cubic centimeters. But even in small prostates, you might think 15 cc's, piece of cake. But if the prostate's too small, I can't get enough seeds in to give the right dose. So there's a range of prostates that are appropriate for prostate brachytherapy. And then I always get MRIs on these patients because if there's already seminal vesicle invasion from the cancer, I can't get seeds reliably into the seminal vesicles so I can treat them well with brachytherapy. So they have to have external beam radiation therapy. Comparison of low dose rate and high dose rate, it's very similar. We can expect to get the same results with either one. Urinary irritation goes away a little faster with HDR, lasts for a little longer with LDR, but 2 years after treatment, these patients are doing exactly the same. So I put together this chart of sort of how I think about patients. And just because it's a red circle is kind of what I favor, but don't use this chart as written in stone. As I said, when I walk into a room with a patient, the plan that I have in mind for that patient oftentimes changes dramatically when I'm walking out of the room. So for low-risk patients, active surveillance, I think we can all agree that the best thing to not cause side effects is not to treat the patient if we think it's safe to do so. With favorable intermediate risk patients, those are the patients with Gleason 3+4, PSA under 10. I think seed implant alone is the best treatment in terms of long-term cure rate and long-term side effects. But like I said, there are some patients that just aren't eligible for it because they've got a long history of urinary issues or their prostate's too big. In unfavorable intermediate risk, those are patients with Gleason 4+3, PSAs between 10 and 20. I really prefer a combination of external beam plus a seed implant in patients who are eligible. In this case, unless I'm treating lymph nodes, I don't think it makes a big difference whether I use IMRT or IMPT, proton therapy. And in high-risk patients, I tend to prefer the option of external beam plus seed implant. And if I'm treating lymph nodes, as I have already pointed out, I prefer proton therapy. For node-positive patients, I don't use brachytherapy. I think that in some ways, the cat's already out of the bag. It's in the lymph nodes. I can give you all the radiation in the world to your prostate with brachytherapy, but I'm not going to fix that lymph node disease. So I think when treating lymph nodes in the whole pelvis, proton therapy gives us superior plans, and I lean toward proton therapy. I will also say that I don't know if Dr. Rossi is going to comment on this. One of the things when I'm talking to patients about proton therapy that I always look at is I hate to dangle the carrot of proton therapy and recommend it vehemently if I know that a patient doesn't have insurance that's going to cover it. And if things are relatively equal, I'm certainly going to more likely recommend IMRT for patients if I don't think their insurance is going to cover proton therapy. But if I see a clear preference, if I see a clear benefit to proton therapy, then we need to talk about perhaps appealing with the insurance and that kind of thing. So I'm sorry that has to enter into all of our treatment decisions, but it's 2022 and it's a fact of life for all of us. So in conclusion, offering a wide range of radiation therapy options allows us to individualize treatment to both the patient's prostate cancer and their own goals. So I think your goals and what kind of side effects you're willing to tolerate and which you are not are very important factors in this whole thing. Proton therapy, I think, is advantageous in a number of situations, but especially when I'm treating lymph nodes. I really like it in the post-prostatectomy salvage setting, and probably also in younger men where I'm worried that their guy is 53 and has a 30-year life expectancy. I'm probably more likely to use proton therapy. And finally, brachytherapy improves cure rates for these patients with unfavorable prostate cancer, and it should be strongly considered, but not everyone is a candidate. Thank you. So with that, I will turn this over to Dr. Rossi, and I will stop sharing.
Thanks, John. Let me get my screen up, and hopefully everybody can see it. Hopefully everybody can see it this year as compared to last year. Just want to make sure you guys can see my slides after. All right, great. After the debacle, so we'll proceed on. I'm going to be giving probably as much of this talk we'll be discussing, hey, what are protons, which to this present audience may be something that the majority of you have heard previously, but just in case you haven't, I like to set that stage, because and I'm sure John has the same experience. We'll have people come into the Proton Center and we'll be doing a consult and talking about radiation, and the patient will say, well, I don't want radiation, I want protons. We have to make it clear. This is a type of external beam radiation therapy. I also would like to mention, and I think the best thing that's happened with us at the Proton Center in the last several years has been the affiliation with the university in terms of improving our ability to take care of our patients, see our patients, and get access to the resources that you have with a first-class academic center. So I've been extremely pleased with that. Now with that, let me see if I can actually advance my slides. So, history of radiation therapy really goes back quite a ways. As Dr. Mundt mentioned, that first prostate patient was treated in 1909, which, when you think about it, was not that long after radiation was discovered. It was the discovery of the latter part of the 19th century, with Röntgen discovering X-rays in 1895. As the distinguished gentleman here on the right, and then the equally distinguished gentleman on the left is Henri Becquerel, who discovered naturally occurring radioactivity. So right around the same time. And with whatever form of radiation that we use, whether it's particle beam or X-ray or radiation given off by a radioactive implant, the target for radiation therapy, the way you kill things, is you create DNA injury. That's how radiation works on the molecular level. You break DNA, and that will prevent, if you create enough breaks, they're not repaired, that will prevent the cell from continuing to grow and divide. It tries to do that. In effect, you've destroyed its blueprint for division, and the cell then dies. Now, we've all grown up, and by we, I mean life on Earth has evolved in a radiation environment. We are getting radiated every second of our lives from cosmic rays, from background radiation in the rocks, etc. And as a consequence, life has figured out ways to repair this injury. We all have in our normal cells, and unfortunately in our malignant cells, the ability to splice out that damage and repair it. The reason that radiation therapy can work is that it turns out that malignant cells have a somewhat poorer ability to repair this injury. So it's a differential cell kill. And in some cancers, the differential is huge. You know, some of the things we treat, the radiation dose required is low. Most adult cancers, that dose difference is not very great. So as a consequence, as we've evolved our technologies, all these technologies, they've been directed at trying to be more specific, to try to crack that window open a little bit more between the difference in repair that the normal tissue has and the malignant cells have. And since we understand radiation physics much better than we understand radiation biology, we've concentrated as a radiation community and a technical community in advancing the physics technology. That's where modern brachytherapy comes from. It's where modern X-ray therapy comes from. And of course, it's where protons come from. One of the things that's also important to realize that radiation it's not a good thing. It's a toxin that we all debate. There's academic debates about whether or not there's a threshold below which toxicity does not occur, but the reality is it's bad for you. And this picture I have here is a monument. It's in Germany to what are called the radiation martyrs, and it has lots and lots of names on it. And they're the names of physicians and physicists and other people who learned and actually died the hard way because they discovered that radiation is the gift that keeps on giving. You know, the Madame Curie died of aplastic anemia, probably from the radiation exposure that she experienced over her decades of work, etc. So anyway, as a consequence of that, we try to make sure we minimize the dose of radiation to the lowest extent possible. And we have these basic tenets of all radiation therapy. Again, any type of radiation. Radiation resistance is a relative thing. It's not absolute. It depends upon the dose that we have to give. And as I mentioned earlier, malignant cells are less able to repair that dose. And this idea about the threshold dose is controversial, but we also have a principle we use in radiation safety, including radiation therapy, called ALERA. Always nice to have a good acronym. And that just means as low as reasonably achievable. The less radiation you have to give somebody in general, the better. So again, we've had all these advances. They're all based upon physics. IMRT, excellent treatment. Protons, brachytherapy, excellent treatment. We're moving into radioimmunotherapy, but these are all physics-based advances. We really do not have nearly as good an understanding of the basic radiation biology, so we can't exploit that very much yet. Now, hopefully that's going to change, and there's some very smart people working on this, but that's why you see the current methods that have been developed to escalate the radiation dose to the bad stuff while sparing the good stuff. IMRT, from the external beam radiation therapy standpoint, is the standard of care. It's a development of X-ray therapy. We're doing three-dimensional reconstructions, as Dr. Mundt and Dr. Einck mentioned. We use those plus computer support to try to be as specific as possible as to where the radiation is placed. There are different brand names of machines that have different operational characteristics that can do this. They're all basically employing X-rays. And this came around in the early 2000s and rapidly became the standard of treatment, primarily because of its superior physics. The fact that we could go back and look in our history of radiation therapy, and again, all these other advances follow the same path. The physics of IMRT and normal tissue sparing were better than its predecessor. There was not a bunch of phase 3 randomized trials that were performed, at least in the US, to say, look, it really is better. We went back to our first principles and said, if I can treat a patient with less dose to normal tissue, I know from past experience that's been an improvement. It's going to continue to be an improvement in the future. And IMRT is a very good way to realize that goal. With IMRT, you do a fantastic job of creating a very specific high dose area. These are two different ways of doing IMRT with either static beams or an arc. Where you see the difference, though, when you're doing this with X-rays is in the dose far beyond the target, because you have to have a dose bath of X-ray beams to get a high dose at depth. There just isn't any way to avoid that with the physics of X-ray therapy. And in general, the larger the area you have to treat, and in particular, the more irregular the shape, the greater that dose bath becomes as compared to a similar proton plan. And this is what Dr. Einck was touching on. For treating a small target like the prostate, there's a minor advantage of protons, but that advantage is really minor. You start having to treat the pelvic lymphatics or in some of the things we do in the kids who we're treating the brain and spinal cord, and that difference in dose bath and under lack of dose bath becomes greater and greater and greater. So be it as it may, again, IMRT is excellent treatment. It is the de facto standard of care for external beam radiation therapy, primarily because of A, its physics, and B, its widespread availability. Protons, as we're going to hear about, have superior physics, but the availability remains inferior largely because of the complexity and the expense of the machines. Where we'd like to get to in the proton therapy world, and we're getting there, is to the point that the cost of the equipment, and equally, if not more importantly, the cost to the payer is no different, that they're writing the same check whether their patients are being treated with protons or x-rays. And that helps to take a lot of the insurance arguments, which are certainly there, off the table. So proton, subatomic particle, it's an every atomic nucleus. It's what determines the physical properties of the elements. It has a positive charge and a mass. The diagram, you cannot give a proton talk without showing the Bragg peak, is named after William Henry Bragg, who discovered this in 1905 when he was shooting helium ions into a water tank. And what he found was, as Dr. Einck described, that you have a low dose on the way in when the particles are going fast at some depth, and it depends upon the energy of the particles and the density of the medium they're going through. They start slowing down, slowing down, slowing down. You get this spike of dose at depth, which is usually about 4 times the entrance dose for a pristine peak. And then the particle comes to a stop and the dose drops to 0. Bragg discovers this in 1904. At that time, he was a future Nobel Prize recipient in physics. He received the Nobel Prize in 1915 for X-ray crystallography. And I think it's cool that he did his work in South Australia. And this is a rendering of the Australian first proton center, which is being built by the University of Adelaide, where he worked. And they've named it after him, which should be operational in a year or two. But you'd have to fast forward to just after World War II to this gentleman, Robert R. Wilson, who was definitely one of my heroes. Great guy to read about. The youngest section head at Los Alamos during World War II. He was a grad student, got his PhD with Ernest Lawrence, who invented the cyclotron. Well, he wrote a paper in 1946 that was titled Radiological Use of Fast Protons, in which he described the potential use, and it was potential at that time, of protons in radiotherapy, taking advantage of the Bragg peak to minimize normal tissue treatment. That wasn't the only thing he did in his career either. He was the founding director of the Enrico Fermi National Accelerator Laboratory. He was a sculptor. That's one of his multi-ton sculptures you see there in the lower right. He designed as an architect some of the Fermilab buildings. Just an amazing, amazing person. And he lived to see all this happen. He passed away in 2000, and we were very fortunate at Loma Linda that he visited us on a number of occasions to see how his 1946 idea had become possible in a medical environment. Proton therapy started in the mid-1950s, Lawrence Berkeley Laboratory, using techniques that are just slightly out of date. I hope you'd all agree. There was a machine with a beam coming out of the side of it, and they would position patients up against it. Harvard did similar work. But it wasn't until 1988 that ground was broken at Loma Linda for the world's first medical proton center. As Dr. Mundt mentioned, we started treating patients in 1990 there. And that center, like most, but not all the newer centers, was designed as such. You have a cyclotron in one corner. This is a schematic of our facility in San Diego. This one particle accelerator serves multiple rooms sequentially. So you're treating in one room while you're setting up patients in the other. And this was done primarily to try to take advantage of making a efficient operation so that you can, have the expense of this equipment and use it in a relatively high throughput. But what's been happening in the proton world, and what is really making a difference in the number of facilities that are being constructed, is the ability to go from a multi-room center like you have here on the left to a single room facility. And this is actually a one-room version of our facility in San Diego, which is the size of a tennis court as opposed to close to a football field. And vast majority of new proton centers, at least in the US, are on this 1 or 2 room model, which is scalable. And the cost, of course, drops dramatically when you're putting in 1 accelerator and 1 gantry versus 3 to 5 gantries, et cetera. Pencil beam scanning is the way that we deliver treatment at our facility. It's the way that all the newer proton centers and most of the older ones have got switched to. It allows you to create a 3D print with protons. You are manipulating the beam entirely electromagnetically, so you can shape it to match complex structures. You can do simultaneous boosting within a target, and you can treat large areas. In my opinion, it's the development of pencil beam scanning which has really allowed proton therapy to go from being a good treatment for rather small specific things to where it can be used for many of the same clinical situations that we use X-rays, including breast and peripheral lymphatics, et cetera. It's let proton therapy become from a utility standpoint as available and as useful in many cases as X-ray therapy. So where we're at right now in the United States is over 40 operational centers. There are a bunch under construction. There are a number of academic centers like the 3 I list on top that have actually built new proton facilities because they needed higher throughput, more capability. In fact, if you look at the list of NCCN, that's that National Comprehensive Cancer Network designated comprehensive cancer centers, there's about 50 of those in the country. The majority of those either have facilities in operation or they're in the planning stage or construction stage. The latest developments have been these one-room facilities. They are far less expensive to build and they take much less time to create and get you up and running. Most of the centers are still in the Midwest and East. There are currently now 5 operational centers in the Western US, of which 4 have pencil beam scanning, and I would consider modern. So for prostate cancer treatment with protons, it's very, 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 very similar in planning and delivery to X-ray therapy. In fact, that's the difference isn't so much the treatment. I mean, the difference is just the modality you're using to get that dose into the patient. All modern radiation therapy is dependent upon 3-dimensional reconstructions of what you want to treat and what you want to miss. That has made a huge difference in what we do in terms of toxicity. Believe me, the days when I used to draw, and Dr. Mundt, and I think John may be old enough for this, I don't want to make him too old, when we used to draw on films with a grease pencil, 2-dimensional X-rays, and oh, we don't like that line, and we'd erase it with a piece, with a tissue and move it. Thank God those days are gone forever. If you saw my handwriting, you really would understand. But it was the best we could do, but we can do much better. And we have all these different imaging methods that allow us to target what we want to do. And you don't use just one. Brent gave examples early on about how MRI is such a fantastic tool for looking in the prostate, not only for biopsy, but also for targeting things. So you do an MRI on top of your CT. You can now do, thankfully, PSMA studies that are readily available. You fuse all these things together to give the clinician the best picture of what he or she wants to treat and what they want to avoid. So all modern radiation therapy requires this. If you look at the prostate with just the CAT scan, and hopefully you can see my pointer, yeah, it's right here between the rectum, which has the balloon in it, and the bladder, but it's just a grayscale image. You have zero definition in most cases within that gland as to the different zones, where the neurovascular bundles are, and where might be some tumor that you want to boost. You do a T2 weighted multiparametric MR, and here you go. You can see in this gentleman's right lateral peripheral zone, there is an obvious tumor. Great. You see that in MR, you don't see that on CT. There it is. That allows you this is a different imaging sequence, which also accentuates that. It's called apparent diffusion. But now if you can see it, you can target it. So what we do routinely at the Proton Center, and this is also done with X-ray therapy as well, and with brachytherapy, is you will build into that area a higher dose, because we've learned over and over again. Dr. Einck gave examples from that Ascend-RT trial and the brachytherapy boost results, that higher doses are better if you can do it in safety. First, if you can find the area, and secondly, if you can do it in safety without exceeding normal tissue tolerance constraints. By the way, you can see here that what the advantage of the hydrogel is for this gentleman by pushing the front wall of his rectum, which would otherwise have been up against this target, when I probably have a hard time boosting it, to way back here. So in modern radiation therapy, the use of hydrogel, whether it's IMRT or protons, has become very, very common. And this is just looking at the same patient cut down the middle, what's called sagittally, showing how we're able to conform the dose, the high dose area to the target and minimize, again, the radiation dose to surrounding tissues. I've been quite excited about this. I suspect that everybody on this call is excited about it. PSMA imaging has been available for several years. I suspect that some of the people on this call have had to travel to UCLA or UCSF to have it done with gallium-68. There's another agent which was approved by the FDA in May of last year. And amazingly, Medicare coverage started in October of last year. I was just pleasantly amazed it happened that quickly. And what we're doing here is, instead of using gallium-68, which is the isotope that they used at UCLA and UCSF, we're using F18, which is a standard, readily available positron emitting isotope in PET scans. We've been using it for 15, 20 years, linked to sugar in lung cancer and other cancers. But now you can take that isotope and you can link it to PSMA and do the same type of scans they do at UCLA and UCSF, but using a much more commonly available agent. And the indications for this are pretty widespread, pretty broad. You can use it as an initial staging procedure in patients who you think are at significant risk for unsuspected metastasis. That's your unfavorable, intermediate risk, high risk, and very high risk patients. It's used all the time in patients who you suspect recurrence based upon a rising PSA levels. And because this agent is readily available, it is now a study that we are doing both at the Proton Center and at the university as of late September, early October of last year. So we're able to get this now here in San Diego at our facilities, and we can use it. We're not having to make patients travel. They're not having to wait 6 weeks, and it is typically covered now under these indications by CMS. So for Medicare patients, it's no longer a coverage issue. And it shows you things like this. On the patient's right here on the screen left, this is a lymph node, like the example that Dr. Rose was giving earlier. If you looked at this just with conventional CT, it looks pretty tiny, but with the PSMA lighting up there, you know it's positive. Not only do you have a verification, you have to include it in your treatment, but you can, again, boost the radiation dose to this area because you want to give a higher dose to that area of known disease. Some quick comparative plans. This is looking at treating prostate alone with in some vesicles with protons versus doing it with X-rays. This is a low dose bath. Is that dose important in most adults? I'd say no. It becomes more important when the patients are younger. It becomes more of an issue when you have a very irregular field. But to pick up on something that Dr. Einck was touching on, I think it's a very good point. In my opinion, for most of the adults that we treat, while there may be an advantage to proton therapy, in many cases, probably most cases, that advantage is at best moderate. We know a lot about what the body can tolerate from X-ray therapy, and we've learned that over the years, and we apply it. So if I have a person who, to answer Dr. Einck's question, who doesn't have insurance coverage for protons, and they're going to have to mortgage their house to get it, versus being able to get very good standard of care IMRT, I'm going to tell them the advantage is not worth you going into that situation, financial distress, to get protons. If it's an 8-year-old child where their differences are extreme, oh yeah, and we'll fight like hell for that. But for most situations, it's a modest difference. Yes, in a perfect world, we like to not treat normal tissue, and this gives you some example of what you can do. But the reality is that for most of the gentlemen that are treated with X-rays, this extra radiation dose will probably be of zero clinical import. So let's look at some recently published data talking about protons and also a little bit about dose escalation. So this is data from the University of Florida. It was and I had mentioned this last year as well. They did a cohort study looking at protons treatment versus similar patients they had treated with IMRT. This was using older proton therapy techniques. Some 1,200 gentlemen treated with passive scatter protons versus compared to about 300 who got IMRT. They use radiation doses that are pretty standard, although I think we've been pushing beyond this for a while. Good, decent follow-up, at least 5 years. And the patients were in both groups received hormonal therapy with different percentage, a little higher percentage of the patients in the IMRT group receiving adjuvant hormonal treatment. Overall, and I think this is also important to realize, there was no difference that they saw in their older patients in terms of overall survival. They did see a difference, and it's a fairly modest difference in their low and intermediate risk patients. High risk patients, again, there was no difference. So either way, you can be treated effectively, and you're probably not losing anything significant in terms of survival. Where they did see a difference was in toxicity, late GI, which is primarily rectal, and GU, which is urinary toxicity. And when we look at this stuff, we look primarily at the higher grade toxicities. We have a 5-point scale we use to grade toxicities. And grade 1 and grade 2, those are at best annoyances. It's the grade 3s and greater that are showstoppers, or at least things you have to do more to the patient to treat. It wasn't high either way. I mean, even in the patients receiving X-ray therapy, the incidence of significant GI toxicity was just over 1%. It was lower in the proton patients. Great. Same thing with GU. This is urinary issues. They were somewhat higher in the X-ray patients, but still not dramatic, 4%, versus less than 1%. But these numbers the differences were highly statistically significant, despite the fact the proton patients got a slightly higher dose. Hypothesis is that's due to the fact that there was a lower volume of these normal tissues receiving a low to moderate radiation dose. Northwestern has done a Medicare database survey, which we always kind of do with trepidation because it depends on how you ask the question, how the data was reported. And they were looking at just over 1,000 patients that they tried to match as best they could to similar patients who got IMRT back again in 2006 to 2012 timeframe. And it was IMRT or protons only, not a mixture, which we used to have to do a lot of in the past. Once again, there was a little bit of an overall survival difference seen in one group of patients. This was primarily due to a decreased number of second malignancies. That's where you saw this difference in survival. We're not talking about a huge difference. We're talking about 5% difference. And the malignancies they were seeing were in the pelvis, which we'd expect because that area got radiated, cancer of the bladder, cancer of the rectum, and leukemias, which are usually due to bone marrow being treated when you have a fair amount of your marrow in the pelvis. There have been some other results presented that this is from a registry trial that we've been involved in at the Proton Center. This is just looking at advanced cases where you're treating the pelvis. And again, the differences were primarily in terms of the rates of grade 1, grade 2, and grade 3 GI, as in large and small bowel toxicity between the proton patients and the X-ray patients. And not surprisingly, there was less acute, which means during and shortly after treatment, GI toxicity in those patients getting their pelvises treated with protons versus X-rays. Second cancers, a lot of interest in this. It's for all sorts of reasons. This is probably the best data set I've seen so far. It was published just about 2 years ago. It's another one of these studies looking at a large number of patients that were treated, and you try to tease out those who got 3D conformal radiation therapy, what we used to do before IMRT or protons, and they looked at the 10 most common adult cancers, followed up to 5 years, et cetera, et cetera. It's a big survey. Is it perfect? Absolutely not. It's not prospective and randomized, but it's hard to do prospective randomized studies of this stuff. And what they found, first of all, was that when they looked at the incidence of second cancers, they were low overall. And there was no difference between 3D conformal, our predecessor, and IMRT. And I think that's important because there were concerns that when IMRT came in the general clinical use, because of the larger amount of tissue that gets a low dose, that this number would go up. And it doesn't appear to be. If you look at the proton patients, though, the rates of second cancer were about 1/3 of what you were seeing in either 3D conformal or X-ray therapy. And that was true across most adult malignancies with the exception of lung cancer. And they did a scatter plot. I'll show on that in a second. But I think this is an important paper because of the number of cases that were studied and the methodology they used. And also, equally importantly, is very consistent. The results are very consistent with what modeling studies based on human data have predicted. And we use these models all the time to talk about radiation safety and such. So it's good we have clinical evidence to validate them. The differences begin to appear, not immediately, of course, but down the road. It would be more important, and again, this is what John was alluding to, that you're going to see this as being more important in people with 25, 30-year life expectancies your prostate patient is 53 versus somebody who's in their late 70s. And this was just a scatter plot showing the difference in the odds ratio for most of the adult malignancies they looked at. Last thing I want to touch on here, and this also builds on what Dr. Einck mentioned. You know, our mantra on radiotherapy is dose, 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 however we can get it. The cancer cells don't know how they're being hit harder. You know, they don't care if they're getting hit with a proton or hit with an X-ray or a combination of X-ray brachytherapy. It doesn't matter. Dose is important. So in addition to that Ascend-RT study, which did a dose escalation with an implant, there have been other trials that have done dose escalation with what's called a simultaneous integrated boost, where you build into your X-ray plan, or that's just on X-rays, a higher dose into that area where you can detect disease, typically based on T2 MRI. And this was a trial that was randomized. There were patients that were assigned either getting essentially a conventionally fractionated external beam course versus the same patients who received this while simultaneously getting a boost to any area of identifiable disease in the prostate, so long as you could do that within normal tissue dose constraints. 5-year follow-up, and their endpoint was biochemical disease-free survival. Is your PSA going up at 5 years, yes or no? And these results were reported a couple years ago, and what they concluded was that if you looked at the two groups, the patients who received this combination, the simultaneous integrated boost with their external beam, had a higher, not tremendously, but it's there, higher incidence of being free of their cancer biochemically than those who received standard treatment. We're talking about 7% difference, but it was strongly statistically significant. And again, equally importantly, at least in this study, they didn't see that there was a difference in the incidence of late rectal or urinary toxicity between the arms, which has been a little bit, that was seen in Ascend-RT with the with the combination patients, and they didn't see it in this. They've more recently updated this where they've said, what's the impact of that? They've gone back and looked at where these patients are failing. You can see these curves are pretty close together, both for what's called local failure recurrence in the prostate and distant or regional failure lymph nodes or metastatically, with the patients who got the focal boost being the red arm. Okay, out here at 7 years, there's a bit of a difference. It is, it does meet statistical significance. It's not huge, but it's there. But when you're talking about treating lots and lots of patients potentially for prostate cancer, those small differences become big differences in terms of the absolute number of people that you may be benefiting. And they also looked at, well, did the dose make a difference in reducing that risk of failure? And not surprisingly, it did. The higher the dose you could get into the area that you wanted to hit the hardest, where there was gross disease, the less likely those patients were to recur either locally and regionally or distantly down the road. We've known for a long time that a locally uncontrolled cancer, a cancer whose primary tumor is uncontrolled, leads to a higher risk of distant failure, and that's exactly what they saw. So in conclusion, proton therapy, thankfully, is no longer boutique. I've been blessed that I was able to get involved in this as a resident, and I've somehow found my way to stick with it now for 30 plus years. And back then it was boutique. It was one facility in the world, and people came from all over the place to get it. That's no longer the case, thankfully, because the equipment is getting to be more widely available. And that's why I talk about this hopefully leading to increased utilization and optimization. Not everybody needs it. Not everybody needs IMRT for everything we ever treat in cancer, but we try to optimize our therapies based upon the clinical situation. We are still playing catch up in particle therapy to adapting some of the other tools that are commonly available in modern X-ray therapy, like onboard image guidance and during treatment and such. And we need to get to the point, we thankfully are, that the cost of doing this treatment to the payer is similar to the cost of X-ray therapy. Now, we're fortunate that for most of the adults we treat for prostate cancer, Medicare has been reimbursing proton therapy of cancer since February 1991. So it's going to be 31 years next month. So for many of our adult prostate cancer patients, this, thankfully is not an issue, but at some point it will be. And before we get to that point, we need to get the cost of the treatment down. We do have evidence that protons in some situations can reduce toxicity, and that includes a reduced risk of second cancers. And it's important that with any of these modalities, and protons are just one of the ways to do it, that we can dose escalate potentially, because that does appear to certainly reduce the risk of developing a recurrence in the prostate or in the pelvis or distantly. And that was just a picture I took yesterday going by Mount Shasta about 3 p.m. So with that, I will say thank you, and I will stop my screen share. And there you go.
Great picture there. Wonderful presentation, everyone. Certainly a huge amount of information there. As one side note, I apologize. This meeting might actually kick us all off in about 3 minutes. So any of the attendees out there that have not gotten their questions in, now's the time.
Well, Aaron, can I suggest something?
Sure.
Because the COVID, it makes asking questions and doing this so painful. So what I would suggest would be questions directed can be gathered by Aaron, and then I will serve as the moderator to get all the questions answered. And so feel free, not at the 3-minute point when we're kicked off and beyond, just send, is that okay? I'm offering Aaron. So send questions directly to Aaron. He and I will be the triage. If there's, I will decide, sort of who's the best, person to answer, the question. And then I will get the answers back to Aaron and then back to the individuals.
So you referred over email, correct?
Yeah, I thought that would be an easier way to do it, but we're happy before the system kicks us off to try to do one or so. But I think it'll be easier if someone, wants to ask a question about their, personal case or something. I can help facilitate that.
Yes, and as John Tassi just pointed out, send us that at the Contact Us link on IPCSG.org website, and we'll get those questions answered if we don't get to answer them here in this webinar. I don't know if everybody noticed, certainly Dr. Rossi and Dr. Rose especially answered a ton of the questions online already. So thank you guys for doing that. So there's not really any open questions at the moment, but why don't I open it back up to Dr. Ross or Dr. Rossi if there's anything in particular you'd want to reiterate, having answered those questions. Was there anything that you wanted to add to those?
No, not at all.
All right, great. Yeah, there were some great answers. Not sure that everybody got a chance to read them while watching the presentations as well. Let's see, one more question came in. Is modified hypofractionation possible after TERP?
Generally it is. You look at what I look at, and I'm sure all of us look at, is what is the patient's urinary status before treatment. If they've had a TERP and they're having horrible problems from it, then maybe radiation at all, it may not be a good idea. But for most of these gentlemen, they're having, in some impact for many gentlemen, having had the TERP is going to make their radiation more comfortable for them because they're not going to have the same issues with obstruction and frequency that they would otherwise have had.
Yeah, I think we've all done it and would be comfortable with that.
Right. Another question, a couple more questions coming up there. So yeah, maybe Dr. Mundt, you want to take over on directing those questions to people?
Oh, I'm sorry. So to the Q&A.
Yeah. So for adjunct radiation therapy, at what minimum level of PSA should a Psma PET exam provide best image results?
I think Dr. Rose addressed this in one of the answers earlier, that really, if it's much under 0.4, we worry that it's too low for anything to be picked up. If PSA is over 0.4, sometimes 0.3, we're more likely to detect cancer. But even in those cases, the lower the PSA, the more likely we're going to find something that that's not related to the cancer at all. So some sort of false positive result. So I always think 0.4.
Gotcha. Excellent. Wondering how focal therapies compare to radiation.
Well, there are focal therapies with radiation as well. I don't know who wants to. The bottom line is there's no direct comparison. In general, focal therapy leads to high rates of recurrence. It's not a standard treatment recommendation for newly diagnosed prostate cancer, and it's not something I favor in any patients other than the salvage setting. I have done focal brachytherapy implants on patients who've recurred either after prior brachytherapy or after external beam. Oftentimes they have disease just on one side, and if you implant half the gland, they do really well. But remember, the other half has already been treated with some kind of modality. So I think that's why they do okay if they've already had treatment.
Yeah, I totally agree with what John said. That I have patients ask me that question frequently, and I tell them that if you want to engage in focal therapy, please do this in the context of somebody's clinical trial. Don't just do it because somebody says they can do it. We're trying to learn from this, and that's the way we learn. The other reason I caution them about focal therapy, if you think back to the data I showed from the FLAME trial and also from ASCEND-RT, locally uncontrolled tumor leads to a higher risk of failure. So if you're doing focal therapy with the intent that, well, we're going to treat the left side, and don't worry, if you come back on the right, then we'll treat the right side as well at some future date. What you're allowing to occur in that situation is you're potentially allowing disease to progress in the prostate because it wasn't treated initially, and that can serve as a nidus for a wave of metastasis. Again, all the more reason if you're going to do this, you find a good clinical trial that is answering the question in a scientific fashion.
Great. Yeah, it looks like we made it past that 12 p.m. mark that I was worried about. So I think we will be able to answer all questions from everybody. So please do submit any more that you have. The next one is I understand it's not possible to get radiation if cancer recurs. Are there promising new therapies that might be functional in 7 or so years?
Yeah. Brent, do you want to try that one?
Yeah, sure. So, I would just say that we often say you can't do radiation again after having it the first time, but that's actually an oversimplification. All it really means is we have to think pretty carefully about doing it again. And we think of it as a case-by-case basis. And like what Dr. Einck was mentioning, it depends on where it comes back. So we'd want to do a very thorough evaluation, trying to make sure we understand exactly where it has come back. Because typically we say it has come back because the PSA is rising, but that doesn't help us to know where it has come back. So in those circumstances, we'd want to do a PET scan, like a Psma Pet Scan, as well as an MRI of the prostate, and then likely follow that up by a biopsy if we saw something. And so if you were to see something in the side of the prostate or a focal area, there are certain radiation techniques that are feasible. Brachytherapy is the one that we typically think about the most because you can control where the radiation goes very well by where exactly those seeds go. But you could also do SBRT or particularly proton therapy, again, because that can help you to avoid some of the sensitive structures, particularly the bladder and the rectum and things along those lines. So I would say that it is possible to do radiation after having radiation before and had a recurrence, but again, it depends and it's on a case-by-case basis. Alternately, you can do other things like HIFU or cryotherapy or things along those lines that don't actually use radiation. And while we both caution that focal therapy like cryotherapy alone might not be the best case in the upfront setting, that's typically because prostate cancers tend to be multifocal, meaning kind of distributed throughout the whole prostate. But once you've had a recurrence, you often end up getting a recurrence in one specific spot. So something like a cryotherapy or a HIFU or an SBRT can actually be an effective mechanism to eradicate disease that's localized just within the prostate. The hard part, though, is sometimes we don't know exactly where it's localized to because the imaging doesn't give us a perfect example or it's distributed throughout the whole prostate. That's a harder scenario. I actually pass that over to Carl because I know that Carl has done a few whole prostate re-radiation cases. So maybe I'll get your experience on that.
Sure. Thank you, Brent. It's been a mixed bag. So I've been surprised both ways. I've had some cases, these are either patients I've had previously treated with protons and then recurred, or they had brachytherapy and recurred, or external beam therapy and recurred. I've had some that have just done spectacularly well. Their PSAs are 0 years after I treated them, they're not having side effects. I've also had a few that have had severe injury from retreatment. So when I have a patient that I see that is coming to me that's had prior radiation of any type and they have a local recurrence, I have exactly the same type of discussion that Brent just mentioned, that yes, we have, I have used radiation, other people have used radiation, it's definitely in the mix. But I think that from the standpoint of safety, that we have better data on focal treatment, especially with cryotherapy, because they have a better ability to control the area they disrupt than we do with radiation. They're going to effectively treat less previously treated healthy tissue. And that is fortunately a situation where a whole gland treatment usually does not need to be done. If you have a patient that's recurring throughout the prostate, which I've had a few of those I've treated, yes, you can do it. That's not a situation where focal therapy is going to be particularly beneficial because the entire gland's at risk. But it also is unfortunately a harbinger for a person who's going to fail in other areas. So then how it becomes a question of how aggressive you want to be. What this really all comes down to, not surprisingly, is you've got to have a really just frank and straightforward discussion with the individual and let him know the pros and cons, and that potentially they're going to be engaging something that could severely change their quality of life and not for the better, and that they have to look at all the alternatives.
The other thing to mention is that we do invariably see some recurrences after radiation, but a recurrence doesn't necessarily mean that you're going to die from your cancer. Often these are very slow, indolent cancers that are, the PSA is rising, but we're really just monitoring it for a long time without doing any types of interventions. And then sometimes we do need to do something, and often that will include hormone therapy. And I know a lot of guys don't love hormone therapy, but in the right circumstances, that will put cancers to sleep for several years, often even more. We've had guys on hormone therapy with controlled cancer for decade, so not just because the PSA is rising, it doesn't necessarily mean that you're going to run into big problems. So that's one of the other things to discuss if you do have a local recurrence in terms of thinking of what are your options, but also what if you didn't do anything? What if you just monitored it? So it's a nuanced discussion that you'd want to have with your doctors, but definitely we as radiation oncologists would like to be a part of that conversation, because often a urologist will say, oh, radiation's off the table. Sorry, we're just going to do hormones or something like that. And so there's a lot more to it than that. So we would like to be involved, at least to help guide those decisions.
All right. Well, on that, I think last call for questions, if anyone has any more, but I would like to say again, thank you for such wonderful presentations. We are certainly very lucky to have all of you both here today as well as in San Diego, and with such a wealth of experience and knowledge. Yeah, I mean, I'm even just the fact that we have, when we look at that map again and see that we have two proton centers here in Southern California, one specifically here in San Diego, as well as the recent advances in it and much greater adoption by insurance companies for it. We certainly are lucky here to have the treatment options that we do. And so with no more questions, I'd like to say, if anyone has any more comments, feel free to chime in. Otherwise, I think we're done.
Thank you.
So,
Well, thank you, everyone.
Bye, everyone.
yeah, thanks, everyone. See you again next month. And guys, definitely see you next year. We'll look forward to it again, for sure. All right. Take care, everyone. Bye-bye.